include duration of diabetes, the glycemic control, the presence of hypertension, then dyslipidemia, and other minor risk factors. But among them, the duration of diabetes and glycemic control, hypertension, and dyslipidemia play a major role in the occurrence and progression of diabetic retinopathy. Macular edema occurs in nearly 12% of patients with diabetic retinopathy and causes more than around 10,000 new cases of blindness per year. Now, the risk factors for diabetic retinopathy and macular edema remain the same, but the role of inflammation it's supposed to be having more impact on the progression and occurrence of diabetic macular edema, and so also the role of dyslipidemia. Now, coming to the modifiable risk factors, there are numerous benchmark trials that evaluated the relationship between glycemic control and diabetic retinopathy, among which the WESDER, that is a Wisconsin study, the DCCT, and the UKPDS both threw a light on the primary and the secondary prevention. They said that intensive glycemic control delays the onset of diabetic retinopathy, that is the primary prevention, and also slows the progression of the existing retinopathy, that is a secondary prevention. Now, DCCT was a multi-center trial which compared the intensive which looked at the effects of intensive control on the occurrence and progression of retinopathy and macular edema. Now, after 4 years after the period of intensive control, it gave us the data that there was a 58% reduction of the clinically significant macular edema, and also the need for lasers also decreased by about 52%. Now, so coming to the relationship between hyperglycemia and macular edema, elevated baseline HbA1c levels are always associated with increased risk of macular edema. The levels of 8% or more have a greater risk of macular edema with manifesting as increased central foveal thickness. So also the renal function and fluid balance play a major role in worsening retinopathy and macular edema. So overall, intensive therapy is most effective in the earlier stages of retinopathy to prevent the eye-related complications, and to have a level of HbA1c equal to or less than 7% would be ideal. Now, coming to hypertension and macular edema, the UKPDS was a benchmark study which threw light on the relationship between hypertension and macular edema, which showed that with intensive BP control, the risk of moderate visual loss and risk of diabetic retinopathy progression significantly decreased. The Wisconsin study also showed that the higher incidence of macular edema was associated with higher diastolic blood pressure, which was independent of the glycemic control and also the antihypertensive drugs used. Now, ACCORD-I study had 3 arms, wherein there was an intensive glycemic control and usage of statins and fibrates, and along with intensive control of blood pressure. Now, this showed that at 4 years, the intensive control people had a benefit of reduction in the progression of retinopathy. So also people who received simvastatin, that is fibrates and statins. Now, advanced trial also showed that diffuse edema is associated with increased cardiovascular disease, and diabetics with concomitant hypertension have 3 times more likely to develop diffuse macular edema. Now, coming to relationship between lipid profile and macular edema, the field study showed that usage of fenofibrates reduced the frequency for laser treatment by about 31%, and they also have known to reduce the concentrations of all these inflammatory substances. So lipid lowering recommendations are always better given to patients with diabetes and dyslipidemia, irrespective of the retinopathy status. Now, severe macular edema can be associated with pre-proliferative or proliferative retinopathy in pregnant women, and which would spontaneously regress during postpartum. So therefore, if macular edema present in early pregnancy with progressive visual loss, laser or intravitreal steroids should be preferred, and better to avoid anti-VEGF. Now, the role of inflammatory mediators have become increasingly clear in the causation and progression of macular edema. So they have changes, or they bring about changes in the arterial or endothelial dysfunction, which may lead to progression of the disease. And also increased cytokine levels have been seen in retina and vitreous. And regarding the therapy to anti-VEGF, inadequate control of serum creatine levels, cholesterol levels, definitely associated with poorer outcomes in spite of good secondary intervention. So also it's always better to have less than 7% HbA1c values to have a good response to the anti-VEGF when given in patients with macular edema. Now, the other risk factors, especially associated with less than 12 grams of hemoglobin, twofold risk of any retinopathy. So, the interesting fact to know is that there is spontaneous closure of microaneurysms on correction of anemia. Now, coming to drugs and retinopathy, thiazolidinediones delays the onset of proliferation but may cause DME. So, the combination of fibrates and statins are known to decrease the occurrence and progression by about 40%. Throwing light on the glitazones and macular edema. So, the glitazones, which would cause fluid overload, results in two aspects. That is, there may be worsening of DME and also the treatment of lasers. That is, if laser treatment could be ineffective. So, therefore, it's better that we switch over to other modes of management so that and reverting or taking back glitazones would definitely help us in the treatment of diabetic macular edema. Now, some risk factors that associated with retinopathy and also diabetic macular edema, especially with obstructive sleep apnea, sleep disordered breathing, etc. Now, the watchwords is having a strict glycemic control, reduction of blood lipid levels, regulation of the systemic blood pressure, maintaining levels HbA1c under 7%, and good blood pressure control, tackling vitamin D deficiency, correction of anemia, and efficient management of non-healing ulcers. And the conclusion, this is definitely an outstanding example of the application of evidence-based medicine. So not only aiming at secondary intervention, the primary intervention also plays a more important role in the management. So hence, multifactorial approach is the key. Thank you so much.